Hello, everyone. I'm Dr. Chen from Taiwan. Thanks for the invitation from the organizing committee of ACEM to provide me this great opportunity to share my experience on gastrointestinal ultrasound. This assigned topic is both interesting and challenging. At the end of this topic, I hope all of you can have a strong gut feeling on using point of care GI ultrasound. I am an emergency physician working in Shuanghe Hospital and spend 2 days every month teaching POCUS in Xinguang Wuhuoshi Memorial Hospital. I use POCUS mainly in emergency medicine, critical care medicine, interventional procedures, and acute pain management in ER. The definition of gut feeling on Wikipedia is an immediate or basic feeling or reaction without a logical rationale. To have a strong gut feeling when you practice GI ultrasound, we should have basic understanding on sonoanatomy of GI tract and know common diseased ultrasound patterns that will be encountered in our daily practice. Dr. Sun Rentang suggested that GI ultrasound can be used to diagnose appendicitis, diverticulitis, intussusception, pneumoperitoneum, and dirty ascites in acute and critical settings. The wall of GI tract has 5 layers. From the outer part to the inner part, we can see serosa, muscularis propria, submucosa, muscularis mucosa, and the interface between the mucosa and lumen respectively. Normal bowel wall thickness should be less than 0.5 centimeter. In order to find GI tract, start your scan from fixed part of the GI tract such as cervical esophagus, EC junction, third portion of duodenum, and structures fixed within retroperitoneum such as ascending and descending colon and rectum. You can use external body landmark to place your transducers, and then find internal landmarks near your targets. For cervical esophagus, it's a superficial structure. Linear transducer is a better choice. Place the probe transversely just above clavicle. Most of the time, the cervical part of esophagus will be located on left side of trachea. It has 5 smooth layers. We can see the gas passing through the esophagus during swallowing. Ultrasound can help to confirm correct placement of ET tube and NG tube. The next part will be EC junction. Place the probe sagittally over xiphoid process. The EC junction is located between left lobe of liver and abdominal aorta. Slightly rotate the probe, we can see the EC junction and the stomach just beneath the left lobe of liver. The typical gastric rugae has an orange-like shape. The third portion of duodenum will pass between SMA and aorta. We can see the fluid and gas passing through the third portion of duodenum. There are folds of Kerkerin inside the small intestine. It is responsible for nutrient absorption. Jejunum has more folds than ileum. The holstration of large intestine will be seen when the large intestine filled with gas, feces, or fluid. For small intestine and large intestine, start your scanning from fixed part of GI tract. That would be both sides of ASIS. Scan between ASIS and costal margin to find ascending and descending colon. Use urinary bladder as window to see rectum. To scan the rest part of GI tract, move your transducer just like you are mowing the lawn. These are the most common pathologic GI ultrasound patterns. When the diameter of small bowel is larger than 3 cm, it is abnormal. For large intestine, the value is greater than 5 cm. When the distended loops are unable to be compressed, think about obstruction. Next, observe the wall thickness and the preservation of stratification. At lesion sites, the luminal content is usually decreased. The diseased bowel loops will have decreased peristalsis. Sometimes the associated findings are more obvious, such as enlarged mesenteric lymph nodes, echogenic fat, ascites, and abscess. There are three patterns can be seen: ascites, air, fat. Search fluid on dependent sites, such as around the liver, paracolic gutter, and pelvic region. Echogenic ascites with floating spot should be considered bowel perforation. To see extraluminal air, look carefully on peritoneal surface, especially on liver surface. Compressed peritoneum can push the air away from the peritoneum. It is the so-called curtain sign. Free air will enhance the peritoneal stripe. It is the EPSS, enhanced peritoneal stripe sign. Gut point in the peritoneal cavity is just like lung point in the pleural cavity. Inflammatory fat will be echogenic. When you see a bright mass-like structure just next to the GI tract, and there is no gut abnormality, consider apoploic appendicitis. In addition to start from fixed spot, try to find external landmark first, then identify internal landmarks near your target. For example, when examining patients presenting with right low quadrant pain, place the probe medial to the external landmark, ASIS, then identify the internal landmarks, such as iliac bone, iliopsoas muscle, and iliac vessels. Then start your scanning along the muscle and the vessels. The arrow in this clip points to the appendix. The distal part of appendix is swollen and moving toward pelvic cavity. Ileocolic intussusception is the most common type in pediatric patients. When pediatric patients presenting with cyclic or periodic patterns, such as crying or vomiting, scan right upper quadrant first, just at the end of Morrison's pouch. Try to find target signs or pseudokidney sign of intussusception. Sometimes the leading point can be seen. Bisection approximation method was proposed by my teacher, Professor Wang. BAM is helpful to identify the lesion site of bowel obstruction. If the ascending colon is dilated and the distal colon is collapsed, the possible lesion site should be transverse colon. This young man has epigastric pain and persistent vomiting for half day. We can see distended stomach filled with fluid. The fluid and undigested food is extending from stomach to second portion of duodenum. The third portion of duodenum is not distended. The patient was diagnosed to have gastric outlet obstruction. We placed the NG for decompression and arranged endoscopic examination for further survey. If the anterior approach is blocked by gas within stomach, we can use spleen as the window to see the dependent part of stomach. These are the ultrasound findings of small bowel obstruction, such as to and fro movement, keyboard sign, and string of these signs, and their corresponding X-rays. Ultrasound is extremely helpful for gasless bowel obstruction. In the hands of trained operators, ultrasound has comparable performance to that of CT for the diagnosis of small bowel obstruction. In addition to scan from landmarks, do remember to scan transversely on the painful regions. We can see the thickened appendix base and the swollen circular appendix. Despite gas can interfere ultrasound examination. Apply steady pressure to compress the tender region can push gas away and reveal the underlying lesion, such as retrocecal appendicitis in this case. The appendix is moving upward. This patient had fever, diarrhea, right lower quadrant pain, and bandemia. We see symmetric wall thickening on thickened and ascending colon with preserved stratification. The luminal content of this segment of colon is decreased. The normal wall and luminal gas faces content of the descending colon is used for comparison. These are typical findings of infectious colitis. This patient has bloody stool and severe left abdominal pain. We can see a long segment of symmetric wall thickening without typical stratification. The luminal content is decreased. Linear ultrasound can provide similar findings with better resolution. These are typical findings can be seen in ischemic colitis. Subsequent CT scan and colonoscopy scope confirm the diagnosis. On the left side, we see infectious colitis with symmetric wall thickening and preserved stratification. On the right side case, the sigmoid colon has a symmetric wall thickening without clear stratification. This patient was diagnosed to have sigmoid colon cancer. CT scan and surgical result confirmed the diagnosis. There are many folds of Kerkerin in this loop. Therefore, this is genuine. This pillar-like alignment is a unique pattern in patients having lupus enteritis. The CT scan has the same appearance. This patient has small bowel distension. We see bowel dilatation, bowel wall thickening with decreased peristalsis. One segment of thickened loop has air trapped within the bowel wall loop. It is the so-called circle sign, indicating pneumatosis intestinalis. Both patients had left lower quadrant pain. This patient has asymmetric wall thickening, echogenic fat, and the dome sign. The AED patterns are usually present in patients with diverticulitis. The other patients had echogenic fat without gut abnormality. This is epiploic appendicitis. This patient has right lower quadrant pain. We can see the AD patterns on terminal ileum. On CT scan, and linear transducer provide better resolution. This patient has typical clinical presentation as appendicitis. It is easily to identify the echogenic fat rather than the target. The typical sausage-like appendix was surrounded by the echogenic fat. Distended and non-compressible loop with blind ending is the direct finding of appendicitis. The echogenic fat is the indirect finding. When those direct findings are not obvious, find indirect findings such as echogenic fat or ascites can be the guidance to the lesion site. Ultrasound can be used to identify the location of misswallowing foreign body. In this case, the coin is within the stomach. In patients receiving peritoneal dialysis presenting with diffuse and severe abdominal pain, sometimes we will see this unique finding. The wall of these bowel loops are too bright, looks like calcified covering on the bowel wall. The corresponding X-ray and CT scan confirm the diagnosis of encapsulating peritoneal sclerosis. In addition to diagnosis, we can use ultrasound to guide our reduction in a real-time manner. This ER patient has ruptured appendix with abscess formation over pelvic region. Surgeon requested CT-guided pigtail drainage first. The CT showed nearly impossible to reach the abscess, and radiologist declined the intervention. My colleague requested my help. When applying the pressure to push the secant away, there is a small pathway between the secant and iliac vessel. I use this pathway to send guiding needle into the abscess and finish the rest part of pigtail insertion and drain more than 70 milliliter pus immediately. To build up strong gut feeling, it is important to recognize normal sonoanatomy of different GI tract: cervical esophagus, stomach, small intestine, and large intestine. Use curved probe for screening and linear transducer for superficial structures such as cervical esophagus and appendix in pediatric patients. Indirect findings such as dirty ascites, extraluminal air on liver surface, or echogenic fat abut the GI tract are extremely helpful to assist diagnosis and clinical judgment. These are my take-home message. Let's grab the probe and see your gut feeling. Thank you.